I'm David Adams. It's my great pleasure to welcome you to the 5th ATS Mitral Conclave.
I'm Dr. Randy Martin, and I'm thrilled to be joined by my dear friend and colleague, Dr. Randy Chitwood. Good to see you.
It's good to see you, Randy.
You got the really meritorious award last year at this, 2 years ago at this meeting, and I think it's obviously well meant. And we want to talk a little bit about what you know so much about the evolution of mitral valve treatments.
Well, it's really interesting because for many years there was nothing that could be done for mitral stenosis. In fact, my uncle died of mitral stenosis. It really started back in about 1909 when one of the T. Lauder Brunton in England suggested that if you could open the mitral valve, the patient would be much better. Well, nothing really happened until 1923 when and at Brigham, Elliott Cutler actually opened up a valve. One patient survived, the next 6 died. And in England, the same thing happened. One patient survived by Dr. Sutar, and the rest died. So there was a moratorium, a pall for many years, until about 1948 when Smithy, Harkin, and also Charles Bailey in Philadelphia, independently, not knowing each other, did mitral commissurotomy. And of course in the 60s, we began to have replacements of valves. But before that, there was some really good stuff done in the United States in repair of valves. But it sort of went away because the replacement, they thought it was going to be better. But as we all know, it's better to have a repair than a replacement. I think what really opened it up in the United States was when Carpentier gave his address at the ATS in 1983. And basically the French correction, teaching us how to analyze the valve, how to repair the valve, and then he proved that better survival, less thromboembolism, and better cardiac function. But there's more to it now.
So that really changed the whole face of how you would approach mitral valve disease.
Completely.
Okay, but then the next chapters?
Well, the next chapter was basically getting people to repair valves, which has been difficult in the United States. But we're up around 70% now of valves that can be repaired. But the next chapter was when we developed minimally invasive techniques. And I did the first videoscopic mitral in the United States in 1996.
Goodness.
And so I did about 600 minimally invasive operations, operating with secondary vision with an endoscope and long instruments, long chopsticks. Then about 1998, I went to California to see this prototype of this robotic thing. Operating with a robot, everyone thought I was nuts, and maybe I was. And so we took that prototype to Leipzig, and with Fred Moore we did 8 cases. And that was a proof of concept. The patients all did well. And there's been an evolutionary process over the years, so there are 4 generations of these robots. They're expensive, there's no question, but almost every hospital has one for urology and other things.
So you were obviously a pioneer in many ways, but why did robotics not really catch on extensively? And it's not because it's not a good technique, and good repairs can be done that way. Was it the instrumentation? The cost of the instrumentation?
Well, everyone.
Or was it sort of, no, I'm a surgeon, I need to operate?
Well, everyone said it was going to be cost. But, almost all of the prostates are operated upon in the United States using a robot. So most hospitals have these devices. And usually it's shared between GYN, thoracic surgery. So that's not exactly the issue now.
Okay.
The hardest thing about this is to build a team.
Okay.
It requires this is truly the heart team. Cardiologists, anesthesiologists, surgeons, bedside, tableside assistant. But once that's done, and you get good orchestration after about 50 cases, it goes smoothly as it did through a sternotomy. The key is the patient benefits. Less blood loss, less ICU time. Most of the time people are getting extubated in the operating room. Our average time, about 70% of our patients went home in 3 days.
Good. Unbelievable. Well, I know, and I didn't mean to say that it hadn't been a valuable technology. It's been an incredibly valuable technology. Let me transition you though to where are we going? Because obviously the next chapter is transcatheter therapies.
There's no question about it, Randy. And I think that surgery will still have a place for certain lesions, but as we know from some of the studies like the COAP trial, that basically when you do a transcatheter edge-to-edge approximation for functional disease, they do better, survivability is better, so that's the proof of concept. But what if you could not only put new cords in, like neocords, and put a ring in, an annuloplasty ring, to remodel the annulus, then you've really got the same repair that we're doing in the operating room. So clearly it's going to be a dichotomy between some surgical therapy, some a simple clip, some with a clip and a ring, or a cords in a ring. It's an evolutionary process. And in parallel, imaging is moving along.
Absolutely.
And that has been the key to this.
You know, just in closing, you've been obviously an innovator. I mean, with everything you've done. And what would you tell the young surgeon or even the young cardiology interventionalist that they need to think about and concentrate on as we move into this era?
I think they need the skills. If you're a young surgeon, you need wire skills. You need to spend time with a cardiologist. If you're a cardiologist, you need to spend time with the surgeons looking at echoes and deciding what to do together. So I would tell them that they need the cardiovascular specialist. And that's what I'm aiming for and have predicted in a lot of my papers. It won't be the cardiologist and the surgeon. It'll be the cardiovascular specialist. One may be imaging, one may be structural, but structural and can operate. And this is way in the future. If all the societies will come together, the professional societies, in maybe 1,000 years. But I think that's the key.
Wake us up and tell us about it. No, well, it's fabulous. I mean, you really have made major contributions. As I said, the award you got at the last conclave was well deserved. Thank you so much, Randy. Enjoyed learning from you as always. Thanks.
I always enjoy seeing you.
Thank you, and thank you very much.